These are my disclosures, and I'd like to touch during this talk upon the use of artificial intelligence for the interventional cardiologist, and mostly cover AI applications in coronary computed tomography angiography, but also AI in the planning and guiding of PCI. Now, CCTA has evolved considerably during the last decade, and it does not only provide anatomical information, but thanks to the use of artificial intelligence, it now also provides information regarding coronary physiology and regarding plaque composition, and therefore it can provide important information for planning PCI procedures. And CCTA is actually now recommended as the first-line imaging modality in patients presenting with chest pain by the US and European guidelines. So we can use AI for the diagnosis of functionally obstructive coronary artery disease, going beyond merely estimating the amount of stenosis. So the use of CT-based FFR was originally based on computational fluid dynamics, and this is very computationally intensive. So it can take up to several hours, even for very advanced computers, to calculate the CFD and calculate an FFR. However, novel CT-based FFR techniques rely on artificial intelligence by using neural networks. And for example, HeartFlow, which now combines AI and CFD, can calculate FFR within mere minutes, and it can also provide information on plaque characterization. And there's other companies out there, including Clearly, that offer Clearly Ischemia, and HemoLens, that offer the CardioLens FFR CT solution. On top of FFR, we can use CT for non-invasive plaque characterization. I think this is important because when we do angiography, we only obtain a luminogram, so we see a two-dimensional view of the three-dimensional blood vessel, and we only see the inside of the vessel, but we don't really see the vessel wall. Maybe sometimes we can say a little bit about calcification, but there's a lot that we cannot see, and all of this we can see when we acquire a CT scan, and not just of one single lesion, but of the entire coronary artery tree. Now, there's several techniques out there, some of them using IVUS or OCT as ground truth, others using histopathological data. I think this is a nice example of what is currently possible with standard CT. So this is an LED diagonal bifurcation lesion, and we can clearly appreciate the extent of the calcium. We can calculate the intensity of the calcium. We can see how the calcium is actually located according to the carina. We can accurately see what the angle of the bifurcation is, and we can see the calcium arc at different points of the stenosis. And not only that, we can also make an assessment of how important the side branch is, for example, by estimating the amount of myocardium that is being subtended by these side branches. Then we can also do a virtual FFR, a CT FFR, and we can do virtual stenting. And you can actually compare different strategies, a short stent, a long stent, a one-stent strategy and a two-stent strategy, and you can already have an idea of what the results will look like after your procedure. Now, there's an added benefit of measuring non-calcified plaque beyond the mere calcium score and also beyond merely the intervention, because we already know for a long, long time that it's actually the amount of atherosclerosis that also really determines the risk of adverse events. So if we know that a patient has a very large volume of plaque, and particularly non-calcified plaque, this identifies very high-risk patients. And we can target those patients specifically to be treated with advanced medication for secondary prevention. So we can think of GLP-1 medication, PCSK9, and maybe novel anti-inflammatory medication. And I don't really have a lot of information about that in this talk, but we can also use FAI, the Fat Attenuation Index, to estimate inflammation in the coronary artery tree, perhaps also targeting patients that may benefit from that type of therapy. We can use the CT to guide our catheter selection. If there's anomalous origin of the RCA, we'll know it in advance, and we can go with a correct guide instead of trying multiple guides before going there. We can omit the visualization of non-significantly diseased vessels, so the procedure can be faster. We use less materials, less dye, and hopefully, if we can do faster procedures, maybe we can do more procedures in a day, making our work more efficient. We can also prepare patients for heavily calcified lesions, so we can consent them in advance. We can even do a sort of a heart team in advance using just the CT, so patients will only have to go on the table once and not twice. We can select optimal angulations and identify optimal stent landing zones. There's some particular use cases for the CTOs as well, where we can really see the true course of the vessel. And CCTA has one big drawback. It is very sensitive, so that's good. When we know that a patient has no disease on the CT, we can accurately rely on that the patient will have no significant disease. But if there is significant disease, and those of us who've got some experience with CCTA will notice, the CT really overestimates the amount of atherosclerosis. But photon counting may be a game changer in this field. Now, photon counting detectors can directly convert single X-ray photons into electrical signals. And this allows for a higher resolution with lower noise, and it can handle stents and calcium because it will not have to deal with blooming artifacts when we're doing these assessments. When we take the AI applications into the lab, we've actually seen a application in real-world use in our previous case during the last session. For angio-based FFR, several of these techniques are out there. However, some of the initially used techniques still require multiple acquisitions and manual correction of lumen contour delineation. So maybe it's not really AI, it's just some sort of an upgraded QCA. Nonetheless, original data showed very good results. This is Favor 3 China, almost 4,000 patients, where they did a standard angio-based PCI versus a QFR-based PCI. And that led to a reduced number of interventions in the QFR group, but also to improved outcomes. As a result, QFR was actually included in the guidelines, and it is now equivalent to FFR or IFR in the most recent guidelines. But then, Favor 3 Europe really put the brakes on QFR. And I think this is a great example of the shortcomings of AI as it is currently, because we know that it's still difficult to use this. Whoever has ever tried this technique in real world, it's just not very intuitive. It still requires a lot of manual correction on our behalf, and it's not really automated or artificial or intelligent. And we now know that this is not the correct way to go. So what we need is a technique more like the Murray QFFR. This allows for single projection, completely hands-off, automatic segmentation of the catheter, of the main vessel, the side branches, and more than 90% of the time when you take a good angio, you can have these results without any manual interaction. The next talk will be specifically tailored towards intracoronary imaging, so I'll be rather quick with these slides. I think it's still important to stress that intracoronary imaging is strongly recommended in guidelines because of its proven benefit in improving clinical outcome. But it can be very challenging to interpret the images correctly and accurately, and it can be time-consuming. I think this is where AI is already making a difference. Everybody who's used the Ultrian system knows that it helps with the automated lumen and EL detection, calcium detection, it has co-registration, and it shows you whether your stent is well expanded. And these are all very important issues that we have to deal with in the cath lab, and this is really made a lot easier by artificial intelligence. I think a really interesting development is also the development of the SpectroWave HyperView system. They use different type of OCT where they can look more deeply into the vessel, so a deep OCT, allowing for improved visualization of the EL. And it includes near-infrared spectroscopy, which is also good for lipid detection. They include in their system AI-powered image analysis, also an angio-based FFR solution. It has co-registration. This is a great all-in-one application. It's FDA approved, but unfortunately it's not available in the EU, and I have to say I'm not completely sure whether it's available here in this region. Boston Scientific also has Avigo Plus for their IVUS, which is a great way also for procedural planning. I will skip on this because I'm sure this will be in our next talk. And ultimately, artificial intelligence can also reduce our workload for the type of work that we don't want to do. Nobody wants to write a report. We'd rather be in the cath lab doing a procedure. And that's what AI can do for us as well. There's already the opportunity to have automated segmentation of the entire coronary artery tree, automated lesion detection, automated thrombus detection, automated calcium detection, and that allows for fully automated hands-off syntax score calculation if we do our angio. So this can provide the data to automatically populate a procedural report very accurately, which can then be used in our heart team and requires no manual intervention. So I think this is one of the great promises of AI in the field of the use in angiography. We've touched on this, but there are important shortcomings of the current use of artificial intelligence. we don't so much use artificial intelligence. We use these offline algorithms to support our PCI workflow, but instead, we really need to use the full potential of AI. And that means continuously updated training of algorithms, true hands-off automated calculation of FFR, but more importantly and most importantly, the implementation of the AI workflow into the cath lab X-ray system without the need for wheeling in additional consoles. All these different companies make all these different proprietary products that then need some license and need some additional consoles, some additional computer, which is a real barrier to its uptake in our clinical practice. So ultimately, the real challenge is to keep it simple, and user input from us as interventional cardiologists will define if and how this will be used in clinical practice. And collaboration with radiologists and artificial intelligence experts is key. So to conclude, AI for the interventional cardiologist will open up new possibilities in data analysis of large data sets. It requires enormous amounts of annotated data. It requires collaboration between data scientists, artificial intelligence experts, radiologists, and us interventional cardiologists. There is an emerging role of CCTA for AI-powered procedural planning and guidance, and there is huge promise for the photon counting CT in this area. But it will also require an updated regulatory process to facilitate entry of AI into clinical practice, and it needs to be incorporated into our standard daily workflow. And ultimately, it will not replace, but support the interventional cardiologist. Thank you very much.